Good afternoon. Welcome and thanks for joining us for today's HIS Talk webinar, 6 Communication Best Practices for Reducing Readmissions and Capturing TCM Revenue. It's brought to you by West Healthcare Practice. I'm Lori from HIS Talk and I'll be moderating. I have a couple of housekeeping items to make you aware of before I introduce the presenters. Attendee phone lines have been muted to prevent background noise. Please use GoToWebinar's questions box in the console to submit your questions to our presenters at any time. The presenters will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a link to the recording as well as a PDF version of the PowerPoint presentation in a follow-up email. We have 2 presenters today. First up is Fonda Narki. Fonda is Senior Director, Healthcare Product Integration within the West Healthcare Practice. Joining Fonda will be Chuck Hayes. Chuck serves as Vice President of Product Management for West. And with that, I'll turn it over to you, Fonda.
Thank you, Lori. And thank you to all the attendees for joining us today. We certainly appreciate you taking the time to join us for this webinar. As Lori stated, my name is Fonda Narki. I'm joined by Chuck. We both work at Health West Corporation on the healthcare practice team. You saw our pictures briefly there for a moment, and hopefully that'll help you connect the face with the voices that you'll be hearing over the next 30 minutes. So as you probably know, the focus of the webinar is transition care management, or what is often referred to as TCM. So transition care can mean many things, but our focus today is really on that transition care from a hospital setting to a home environment. So looking at the agenda or the learning objectives, what we'll cover today include, first, recognizing the top causes of hospital readmissions. Specifically, we're going to talk about the addressable hospital readmissions since that's where we can make an impact. Second, we will quantify financial impacts of Medicare's readmission penalties and speak to key requirements of Medicare's TCM 99495 and 96 reimbursement programs. Third, we'll show you how to calculate potential TCM reimbursements and ROIs for your organization. And then really the main focus of our time today will be spent speaking to the 6 best practices for leveraging automated patient communications to help scale your outreach program in a TCM environment. So let's get started. So first, what I want to do is just take a minute and highlight the steps that Medicare has taken to drive improvements into the care of transition patients. There's really 2 concepts at play here, what we like to call the carrot and the stick. And so the carrot's really the ability for healthcare organizations to bill additional dollars for patients who are not readmitted within 30 days and who meet certain criteria. And then the stick really speaks to the penalties that can be applied to healthcare organizations who exceed those 30-day readmission targets. So on this slide, and starting with the stick, we have on the left side kind of the historical events that have occurred over the last few years that really speaks to what CMS has done to drive improvements into the readmission rates. And then what we've done is taken that, and if you look at the chart on the right, it shows what's the impact of these changes. So CMS has been making these changes, what's the impact? And it's interesting to note that the initial release of these changes did make an impact and did cause a lower readmission rate. But you can see that that rate of change has just really flattened out since 2013. So our point of view at West is that it's becoming more difficult to impact readmission rates as CMS continues to add additional conditions to the TCM program. 2 other notable things on this slide is first on the box on the lower right, we've documented the conditions that are currently part of the TCM program, as well as we've included what will be added in 2017. And then really most importantly, it's important to note that 76% of all hospitals are projected to face $420 million in readmission penalties this year. And I think we can all agree that's a lot of money. So now we're going to move to the carrot side of the equation. So on this slide, we highlight again what CMS has done in terms of offering this reimbursement for transition care management, and it really kicked off in January of 2013. Those reimbursements range anywhere from $173 to $243 per patient who meet the requirements. Basically, transitional care services, as defined here, speaks to the 30-day post-discharge period and includes services such as that initial outreach within 24 to 48 hours post-discharge. It includes care plan management, helping the patient understand and follow their care plan. It also includes medication reconciliation and adherence, making sure the patient has the right medication and is taking that medication as prescribed. And then finally, it's helped that patient coordinate any follow-up care or the follow-up care that's required. And then one more note in terms of the TCM requirements is that these services do need to be delivered by clinical staff members as defined in that last bullet. So over on the right-hand side of this slide, what we've done is we've kind of highlighted the key criteria for earning the reimbursements under the TCM 994, 95, and 96 codes. And really what you have to do is first you have to communicate with that patient or caregiver within 2 business days. And then second, you have to ensure that patient participates in a face-to-face visit within 7 to 14 days of the discharge, depending on the complexity of their health issue. So what we've done is we've kind of taken that information, the revenue or the carrot side of the information, and we've done some back of the math envelope estimates. And really for every 1,122 qualifying patients that discharge per year, an organization can earn $217,600 in TCM, which is, in our opinion, that's a nice chunk of change. So I think we all agree that lowering penalties and increasing revenue is a good thing. But what we want to do now is kind of talk about some of the primary reasons that a patient is readmitted to the hospital. So now on the next slide, what I'm going to do is speak to what we call addressable readmissions. And what we mean by that is that there are steps that can be taken in these cases to help reduce readmission. So with that, some of the addressable readmissions happen when, number one, patients do not take their medications as prescribed. I think there are a lot of stats out there about medication adherence and the cost to the organ or the cost to healthcare systems and the systems in general. But just as a fact, CMS estimates that 11% of all hospital readmissions are due to lack of medication, and that these readmissions are at a cost to the system of $100 billion. Secondly, that the patient fails to follow through on that follow-up visit. They either do not make the appointment or they schedule it and then fail to show up. Sometimes the patients have that best intention. I'm going to follow doctor's orders, but they actually fail to execute. And so what we're going to do is we're going to talk about how you can circumvent that problem in a moment. The third reason for an addressable readmission is that the patient doesn't recognize or call to attention red flags or worsening conditions until it's really become a critical situation. And at that point, sometimes it's too late to manage other than another outside of just another admission. And then the fourth reason is the patients basically do not follow their care plan. They walk out of the hospital and they disengage. So they really weren't planning to engage once they've left the hospital. And then finally, the fifth note that we have here, we think it's important to note that chronic care patients are really at a higher risk of readmission, and that organizations really from a priority perspective should really pay particular attention to these folks as they are discharged from a hospital. So hopefully that gives you some good background, and what we're going to do now is kind of switch to what can be done to help prevent these U-turns. So what can you do as an organization to minimize those U-turns back to the hospital and then maximize the opportunity to earn TCM reimbursements? So what I'm going to do now is turn it over to Chuck, who will talk about the 6 communication best practices. Take it away, Chuck.
Thank you, Fonda. And like Fonda was saying, hospital readmissions have plateaued despite the fact that there's 76% of hospitals out there facing CMS readmission penalties. So the purpose of this webinar is to discuss the steps necessary in preventing these U-turns while still earning TCM reimbursements. Now, your first step actually occurs within the hospital. And here you really need to engage the patient to assess their communications needs post-discharge. And this is really crucial for the overall success of your TCM program. And second, per CMS guidelines, you must make 2 attempts to contact the patient within 48 hours of their discharge. Third, communicate with the patient or the proxy by their preferred communication method. So you may have a situation where older, sicker patients might prefer a voice call, while the younger care proxies might prefer a text. Fourth is persistence. So CMS requires the 2 follow-ups be made within 48 hours, but even if you don't connect, you can still be reimbursed for the TCM visit so long as you can get that patient in within the prescribed timelines. After 48 hours, the messaging really changes in nature to focus on getting the patient in for that follow-up visit. Fifth, use smart reminders as part of your overall communication program, and we're going to cover several best practices when using outbound communications to drive patient action. And finally, we're going to look at the use of automation. So we need to look at ways to overcome the biggest stumbling block of any TCM program, and that really being a cost-effective way of scaling up your program. Now, all of these steps might sound like a lot of work, and they are if they're done manually, but we're going to look at areas where smart application of technology increases the outreach without you having to add a whole lot of bodies or infrastructure. So one of the keys to transitional care success is planning patient communications post-discharge. You know, we really have to have an understanding of who's going to be handling these communications on behalf of the patient. Is it going to be the patient themselves, or is it going to be someone else? And consider the situation where you're relying on speaking to the patient. You know, patients are not only recovering from an illness, but they've also been sleep deprived in many cases, been on calorie restricted diets, or have effects from the anesthesia. Now, according to an article in the Archives of Internal Medicine, it's really a best practice to have the patient's cognitive skills assessed prior to their discharge. You know, like, we really need to gain an understanding here. Can the patient understand instructions from their care coordinator, answer questions about their health, and make arrangements for their transportation to their follow-up visits? So the cognitive study is really important, because if the patient can't handle post-discharge communication, then a proxy must be identified. And once this proxy is identified, then you must capture permission to communicate with that proxy and also capture their preferred means of communication, maybe even extending that to the best time of day to reach them. By identifying the best person to communicate with, you really set yourself up for success post-discharge. You know, you need to remember to tell that patient or the proxy to expect a call within a day of discharge. Further, while the patient's in the hospital, they need to be trained up in identifying all the red flags in their health. You need to educate them on how to communicate these red flags to their care coordination team. And if the patient feels like they really are worsening, you can reduce ED visits by informing the patient on how to reach a care team member after hours. So the proxy needs to be kept in the loop as well to make certain that that patient is following your care plan. So finally, before discharging a patient, set up their follow-up TCM appointment and communicate that date and time to the appropriate contact. And take that time to inquire as to whether they're going to have transportation problems or they're going to have issues with obtaining medication prescriptions and so forth, because any issues can be addressed at that point according to your hospital's policies. So the CMS TCM program requires that you make 2 attempts to contact a patient within 48 hours of discharge. Really, that first attempt can go out the first day, first 24 hours, with the second attempt being made the following day if you didn't reach them on the first day. But if you implemented step 1, you've really reduced your chances of not reaching anyone. But in any case, these first 2 attempts are essential, because even if you don't reach the patient, CMS will allow you to bill for a TCM follow-up if the 2 calls were at least attempted. So the purpose of this early call is really about reconciling the patient medications and determining the patient's status post-discharge. Are referrals or labs needed? And verifying that the patient has their medication and is taking them as they prescribed. You can go ahead and take this opportunity while you have them on the phone to remind them of their upcoming appointment and ask if they're going to have any issues making that have arisen since they've been discharged from the hospital. Now, the initial calls are really best handled by automation to scale out the TCM program. You can use text, voice, email, or any of these channels for the initial calls. Any of the channels can direct the patient back into your call centers. Use your internal resources just to practice at the top of their license. The voice messages themselves can be customized so that in the event that you reach a voicemail or an answering machine, the message will be different and leave a number for them to call back on. So here we have an example of using an inexpensive technology for the outreach to do the legwork of the patient chase. We can go a step further. We can actually use automated surveys to track a patient's progress. And if the patient's response to the health survey indicate worsening health, then that call can transfer automatically into your call center, where a care team can handle only the exceptions rather than trying to broadcast survey an entire patient population. Or let's say that we use a survey for to track medication. If a patient indicates that they're not taking their medication, we can use the survey to find out why. Again, the call could be transferred into your call center. We can find out if it's a case of they just can't afford their medication, they can't get to the pharmacy, or the medication might be making them feel worse in some way. Finally, automation simplifies the documentation of all your outreach. Most systems today log the results of calls, such as your no answers, your voicemails, or your transfers. And this greatly simplifies your record keeping and can become incorporated as part of your overall hospital workflow. So it comes as no surprise, given the focus by CMS, that most readmissions occur within the first 30 days post-discharge. If we go back to that Archives of Internal Medicine article on care transition interventions, we can see how effective proper pre-discharge and support post-discharge is in reducing readmissions. Now, this was a 2006 study, but is still the foundation of many modern readmission reduction programs. In fact, this study showed a combination of pre-discharge cognitive analysis, quick post-discharge contact, and weekly health monitoring calls reduced same diagnosis readmissions by 2.8%. But what's more important to this conversation is that 30-day readmissions were reduced by 3.6%. Now, this study annual outreach and home visits, but even then it was demonstrated that a cost savings of over $500 per case could be reached. So the study really suggests that a continuity of care post-discharge fostered a sense of caring, which in turn led to greater patient engagement. Well, let's jump to current programs. Well, last year at HIMSS, a major Pennsylvania hospital presented the results of an internal study where they used text, voice, and emails to communicate with heart failure patients post-discharge. The program was really simple. They only used 2 to 3 messages to their patients in their care proxies. One message was sent right after discharge, and then there was another sent right before their follow-up appointment. And the second message was nothing more than a simple appointment reminder. But by communicating in the preferred communication method and in the language of the patient's choice, readmissions were reduced by 25% over patients that were not messaged. And so overall, readmissions were reduced from 27% in the control group to 16% for messaged patients. Now, one of the keys to effective outreach is to communicate by the patient's channel of preference. And most EHRs today capture that preference. However, it's really important while the patient is in the hospital to verify and update this preference as part of your pre-discharge process. You really have to evaluate that patient on their current capabilities. I mean, for example, if you had a patient that preferred email, but they're being discharged, is it still the case that they can get to and operate their computer once they're at home? You also need to capture the preference of the care proxy. Now, studies have shown that most care proxies prefer text, but voice and emails are requested often as well. Now, this is the time to collect express consent and HIPAA waivers from your patients and their care proxies. You need to protect yourself from any concern of TCPA or HIPAA violations as you make these outreach. So when it comes to preferences, we really do see that one size does not fit all. Capturing channel preference, the time of day, and so forth maximizes the engagement with your patients. So for TCM reimbursements, CMS expects 2 attempts at contact within the first 48 hours of discharge. But what happens if you make these attempts and you still can't reach the patient? Well, the important thing is don't give up. Remember, if the patient comes in for their follow-up appointment, you can still claim the higher TCM reimbursement. So your strategy needs to shift, and that shift is to get the patient in for their appointment. So plan on sending out 2 reminders out before the scheduled appointment. The first initial reminder goes out a few days ahead of the appointment and really doesn't require a response. It's just a simple reminder of the upcoming appointment. However, a second reminder goes out 24 to 48 hours before the appointment as a final reminder. Now here we do ask the patient or their proxy to confirm or cancel the appointment. Now, on occasion, you may have doctors who really push for human contact with their patients. And if this is the case, consider outsourcing your TCM follow-up calls rather than adding bodies or building out infrastructure. Companies in the business of supporting manual outreach have advanced dialing software, so they maximize the connection rate with patients, and they can lower the cost of manual intervention. Use of these services saves your time for the inefficiencies of manual outreach and allows them to focus on patient care. As your strategy shifts from a TCM post-discharge follow-up call to appointment reminders, you're going to want to make use of smart reminders. Now, smart reminders are fully automated, and it's a very cost-effective way of reducing no-shows. Smart reminders are bidirectional, allowing you to receive a confirmation that a patient intends upon keeping their scheduled appointment. But you need to be prepared for cancellation and reschedule requests from patients. By allowing a patient to transfer in to your call center for a reschedule call, or by flagging a cancellation for follow-up, allows you to keep that patient within your system for follow-up care. Now, I was speaking to a CMIO recently, and he was telling me he really felt the money was in knowing who was canceling. And the reason he said this is that by knowing which patients cannot keep their appointments allows you to fill those empty slots from a wait list and allows you to generate more revenue while improving the patient care. Automated messaging allows the patient or proxy to be immediately transferred into your call center to reschedule their appointment while it's top of their mind. You know, when we're doing our outreach, we often see questions come back from patients, and one of the most common questions that we see come back is, where are you located? Smart reminders will automatically provide the location of the follow-up appointment to your patients without any interaction on the part of your care team. This cuts down on the number of calls into your call centers or your practices, and it really gives the patient a better overall experience with your organization. What is so impressive is just how effective an appointment reminder can be. Joslin Diabetes Center implemented a TCM program, which included reminding patients of their upcoming post-discharge appointments. Now, prior to rolling out this program, Joslin experienced a 50% no-show rate for follow-up visits. But once they implemented reminders, no-shows dropped to 7% within less than 2 years. Now, this is a very dramatic improvement and clearly results in better patient care and more revenue, prevents readmissions, and keeps the patients engaged in their care plan. So by this point, you can see how a proactive program of outreach reduces readmissions and generates TCM revenue. The combination of technology and human touch is powerful because patients speak with humans for important health status follow-ups, but the technology does the rote work of the patient chase and allows you to scale up your TCM program to cover all your discharges, not just those most at risk. The important thing to remember is that not every interaction needs to be live. Simple messaging like appointment reminders and lab results are just as effective when automated as when they are done manually. Technology can be used to support a TCM program, using automated surveys to capture health status or track medication adherence post-discharge. And when you couple these surveys with an inbound channel, then these surveys are really an essential tool for reacting quickly to worsening patients. Now, we are seeing strong interest from organizations interested in consolidating their call centers in the hopes of providing a better patient experience. Now, hospitals are applying tech to anticipating the reason for a call to help with efficient call routing. As the patients are routed through the system, call center screens can pop up with information on the patient, saving time and effort both on the part of your call center and on the patient. This same technology now can be applied to route calls to outsourced care teams to take care of overflows or have after-hours conversations with your patients. A final example of how automation can offload rote work from your team is from Howard University. Using appointment reminders, Howard University was able to decrease no-shows by 48%. Howard communicated to the patients by their preferred method and in the language of their choice. And they found this to be a very effective way of getting patients in the door for their appointments. So not only is automation cost-effective in scaling outreach, it can also free up your internal resources to focus on patient care. In the case of Howard, FTE costs were reduced by $110,000 per year. Simple appointment reminders should become automated to give you the best ROI for your TCM program. So at this point, I'm going to hand it back over to Fonda. And Fonda's going to show you how to put together a program using automation to capture TCM revenue, while at the same time reducing the likelihood of readmission. So thank you, and back to you, Fonda.
Thank you, Chuck. So what we're going to do now is kind of take this and put it all together. So how can you easily form a cadence of communication interventions and drive improved patient engagements and outcome? Well, like I mentioned, it's pretty straightforward. So step one on day 0. So as Chuck talked about, you have to engage with that patient pre-discharge. So in addition to having clinical instructions, the cognitive evaluation, the caregiver proxy determination, it's important that you share with the patient and the caregiver what to expect from a communication intervention perspective. When are you going to call? How are you going to call? Are you going to, or what is your channel preference? How are we going to communicate? Is it email? Is it text messaging? A patient that understands how that communication is going to occur is more likely to engage. And as we mentioned, that also applies to any caregivers or proxies that are part of that post-discharge care for that patient. Second, in that day 1 to day 2 time period, we've got to be reaching out to that patient and assessing how they're doing. Are they feeling better, the same, worse? Are they taking their medications as prescribed? Were they able to pick up their medications? Do they have their follow-up visit scheduled? Are they planning to attend that visit? Those are all really kind of key things in that first 48-hour post-discharge that it's critical for a healthcare organization to understand. Third step on that day 3 to 14 is to send that appointment reminder, making sure that that patient intends to make it to their appointment. You know, you heard Chuck reference several studies that show what kind of impact a simple appointment reminder can make on the no-show rate, which we all know will ultimately improve the readmission rate. And then finally, at the 30-day mark, document and bill TCM for the patients that met that criteria and did not readmit. So finally, on the last slide, what we're going to do is wrap up by sharing how these 6 communication best practices can help you achieve key goals in your organization. So by following this cadence of communication in a TCM program, it will enable you to maximize the likelihood of keeping patients engaged in their post-discharge plan. It will help satisfy the TCM program requirements, which will then lead to the third bullet, which is retaining revenue by lowering those readmission rates. 4, as Chuck talked about, it'll help improve clinical efficiency by reducing no-shows to follow-up appointments. And again, reference several studies that show what kind of impact that follow-up can have. 5th bullet, scale your outreach program in a cost-efficient manner. Redeploy the people that are kind of dialing for dollars to more of a care scenario where they're actually taking care of patients versus picking up the phone and trying to chase patients down. It is important, again, that you have to use the right mix of technology and people, though, to make sure that you are maximizing your patient outreach program. And then finally, and I think most importantly, it will help improve the health and overall well-being of your patients. So hopefully we've given you some insight today on how you can help empower your organization to achieve key goals in transition care management. That concludes all of our formal material. Chuck and I would like to thank you for your time today, and I will turn it back over to Lori for the final portion of the webinar. Lori?
Now we'd like to open it up to the audience for questions. As a reminder, please use the questions section on the GoToWebinar panel to submit your questions for Fonda and Chuck. The first question: can an LPN or MA perform TCM services under the oversight of a physician?
Yes, Chuck, I didn't know if you were going to step in on that one. And yes, it does have to be under the clinical guidelines that are published by TCM, but as long as the right oversight is being maintained, then the answer is yes. And I will check with you to see if you concur, Chuck.
Yes, Fonda.
Thank you.
Okay, the next question: can you please give more information on the setup of the first step, the contact in the hospital? Do you recommend having resources go out into the hospital, and what clinical level do they have to be?
Yes, I think probably the very best answer to that question is from that article from the Journals of Internal Medicine. They actually describe the level of the care coordination team that was used at the various stages. I don't have the information right in front of me, but it was a nurse that was trained up in the cognitive test. The cognitive test was really a 4-question test. They asked the patient their age, their phone number, the name of the facility they were in, so forth. Any patient that didn't answer at least 3 of those questions correctly was deemed to have reduced cognitive skills. and then they reached out to try to find a care proxy. So that is a phenomenal article on the pre-discharge process. I would really advise that you pull that down from JAMA and take a look at it. It will answer a lot of your questions.
Okay. Of the three channels, text, voice, and email, which is most effective in obtaining a response back from a patient?
Yeah, text blows every other channel away, and it's really due to the nature of text. I mean, a text stays on your phone, and you can answer it when it's convenient for you to do so. So you can get answers or responses to text throughout the day, whereas when you're calling a patient on the phone, let's say, they have to pick up the phone while it's ringing to respond to you. So we see response rates with text 2 to 3 times higher than we see over any other channel.
You mentioned text is the most effective means to communicate. Are you aware of any technical options which automates the communication aspects which are post-discharge? What pros and cons have you observed with those systems?
Yes, well, I think there's actually going to be another webinar coming up on how you automate the automation, which actually talks to that very topic of how you actually can use automation and have a prescription, in effect, to cadence the messaging out to a TCM patient on these different call patterns that we described, the early outreach within 48 hours, and then sort of this a few days out from the appointment having yet another reminder go out, and then the final reminder actually asking for that confirmation. There are tool sets coming online, and all of this is relatively new. There's not a lot of market feedback just yet on this, but we're seeing the market move in this direction to take automation to the next level so that you have this controlled cadence of messaging out to a patient.
If you use automation to message a large group of patients, won't that bury your call center and result in patient dissatisfaction?
Yeah, that's a good question. Now, all the vendors that I'm aware have some sort of call throttling technology, which will allow you to send out messages throughout the day. So not all your messages are going to go out at 8:30 in the morning. They're going to be spread out from 8 to 5 so that you don't have that situation develop where your call center is just buried.
Okay, thank you. What do you do about patients who don't like technology?
Yeah, and that's one of the preferences you need to capture. I mean, if there's a patient that really doesn't like the technology, then you will have to fall back to the manual outreach methods. Now, I think it has to be put in context, though. We currently use automated surveys to reach out to the chronic care patients for some of our clients. And so long as the patient is advised that this survey, while it's automated, is part of their care plan and is reviewed by people, by humans, as part of their care plan, then it meets with a lot greater acceptance. In fact, what we see is that responses to these surveys can hit as much as 70%. So it really comes down to patient prep. If you tell a patient that expect to receive a survey, every Thursday, and it's going to ask you these 9 questions, it's important that you respond to these 9 questions so that your care coordinator can see what's going on with you. And if it's positioned in that fashion, the resistance to that technology tends to fall away. But I mean, ultimately, if the patient really just says, I've got to have a human to talk to me, then it's something that needs to be addressed within your organization.
Okay, thank you. It looks like our last question is, how do you avoid communication fatigue?
Fawn, do you want to take that one?
Yep, sure, I will. Mm-hmm. And that's a good question, and that is kind of an industry buzzword that you kind of hear now is this communication fatigue. Chuck mentioned this a minute ago, but there's really this concept of organizing and curating all of your communications to patients, regardless of what state they're in, regardless of whether they're chronic, transition, just routine patients, and really having that 360-degree visibility into the communication cadence that's going on, and then really adjusting it accordingly. You don't want to be, it is a concern, and it is something that You don't want to bombard the patient with so much communication that they start ignoring it and being resistant to it. So like Chuck talked about, there's going to be another seminar coming up where we're going to talk about automating the automation. And what that does include is really making sure that it's not just the communication on a one event type basis, but it's looking at the patient holistically and the communication with that patient holistically.
Thank you. As I said, that was our last question, so we'll be concluding the webinar. I want to thank everyone for joining us today, and thank you, Chuck and Fonda, for the interesting presentation.